All right. Good afternoon, everyone. Thank you so much for taking some time to join us to talk about the Unified School Behavioral Health Action Plan. Heather, can everyone see my screen? I just wanted to confirm that the sharing is working.
Yes, ma'am, they can.
Great. All right. Well, first I want to introduce myself and my co-presenter. So I'm Hanalea Hoperman, Senior Advisor for Children and Families in the Office of the Secretary at DHHS. Ellen, you want to introduce yourself?
Hi, everyone. My name is Ellen Essick, and I'm the Section Chief for the Healthy Schools section at the North Carolina Department of Public Instruction.
Great. So Ellen and I worked very closely on the Unified School Behavioral Health Action Plan. So we're going to be talking about that today and about a little bit about what we know about the relationship between alcohol use and school health. So Ellen, you want to go ahead?
Sounds great. So I just want to start with some data and give you all some ideas of some of the data that we use to help direct some of our programming, and hopefully you can use it as well. We collect data from students via the Youth Risk Behavior Survey, and I hope some of you have heard about that before. The survey actually asks students in middle school and high school about certain behaviors that contribute to mortality and morbidity. And those include unintentional injuries and violence, sexual behaviors, alcohol and other drug use, and I'm going to share some of that information in just a second, tobacco use, unhealthy dietary behaviors, inadequate physical activity. We ask about obesity, and then based on requests from our partners, sometimes we have other priority health issues, depending on what data is leaning us toward at any given time. And the one most important thing to remember about the survey is it's probably the only source of data that we have in North Carolina that comes directly from our students. So it's their voice, it's what they tell us they need for their health. A little more about the survey. Um, we conduct the YRBS at the middle and high school levels, and we've done that on odd number years since 1993. So we've collected this data for a long time. The data that I will share today is primarily from 2011, so kind of in that last decade period, but we have data that goes back to 1993, so we can look at trends over time. All schools and classes that participate in the Youth Risk Behavior Survey are randomly selected. So no one knows who's going to be selected until the selection process occurs. Participation is voluntary at each level. That means both at the district level, the school level, and the individual student level. So a student could choose not to participate. It's designed to be completed in one class period, and in the last few years, we moved to an online administration, and it actually can be completed much more quickly. Our students can use computers very efficiently, and they can finish in less than a class period. It's completely anonymous. There's no way we can tell. We often get asked that question. There are no identifiers, and there's no way we can tell which student answered which question. And it is required that schools send home a parental consent form in order for students to participate. So a little about the data that we have related to alcohol use, as that's most important for this group. The percentage, and these are high school students, the percentage of high school students who currently drink alcohol has actually gone down. From 2011, you see it was 34%, and it's gone all the way down to 19% in 2021. Just a caveat about 2021's data. For the first time ever, we did the YRBS in the fall instead of the spring in 2021. And we did that because in the spring, many students were out of the building due to COVID, and the CDC requires that the survey be done while students are actually in school. So we've seen that drop in high school. The next slide, the percentage of high school students who usually got their alcohol by someone giving it to them. And you can see that has stayed about the same, but then went up in 2021. So we saw some increases there. The percentage of middle school students who usually got alcohol, the alcohol they drank by someone giving it to them. And if you see that break there in 2015, that's because we did not get weighted data at the middle school level in 2015, and don't want to include data we're not sure is representative of all of our students. But we did see a sharp increase from 2019 to 2021. in students that got alcohol from someone else. And this is a new question put on at the request of one of our partners. The percentage of high school students who reported that they drank vodka or some other type of liquor as the alcohol that they drink most often when they do drink. 36% said that they use something like scotch, bourbon, whiskey, rum, vodka, if they drank in the 30 days before the survey, when they drank 30 days before the survey. And then we looked at how many of those were males. So 40% of our males said that they drank that type of alcohol. You can see the other by grade level, and then our Black students drank that type of alcohol. At 58% of them, that was the choice of alcohol if they drank, when they drank, excuse me. Then we ask our students if they are riding with someone who's been drinking alcohol, and that has consistently gone down. It's just been a gradual decrease over time as there have been more education campaigns and students have learned a lot more about driving while impaired. So that has gone from 21% in 2011 all the way down to 12.7% in 2021. So we have seen a decrease in students who rode with someone who had been drinking. And that's the high school. The next slide shows the middle school level, and that has also gone down a little higher than high school, but middle schoolers have less control over who they ride with. If they're riding with a parent, for example, they don't have a lot of control over whether they are riding with a parent who's been drinking. So that's our alcohol related data as it relates to some of your work, but also wanted to move in to set up for Hanalea's discussion moving forward on some of the mental health data. The data you see in front of you is the National Youth Risk Behavior Survey data. These are some trend lines. All the data hasn't been released yet, but some trend lines have been, and this one's a very significant one. The blue line is the students who experience feeling persistent or sadness or hopelessness. And the rest of the question says, to the extent that they stop doing their regular activities. So in other words, the percentage of students who are depressed. And nationally, that has gradually gone up, but significantly gone up since 2017. So 2017, 2019, and 2021, we've continued to see that really high increase, big increase among students who are depressed. The red line are students who say they seriously considered suicide. And that, while it has stayed stable for a very long time, also began going up through 2019 and 2021 nationally. And then the gray line are those students who made a suicide plan. And that has stayed about the same, but it gradually is creeping up, a lot like much of our other data. Now, the next slide is going to compare that to North Carolina. So this is what our students say in North Carolina. The percentage of students who experienced that depression in North Carolina, if you look from 2011, it was 28%. And in 2021, it's 43%. That is a huge change, a significant change, and one that really drives a lot of our work right now as we're trying to address the mental health needs of our students. We also saw an increase in the students who said they seriously considered suicide. That has gone up significantly, particularly since 2017. It stayed stable for a long time, and then we saw a real increase. And then the percentage of students who made a suicide plan has also gone up since 2017 significantly. So again, our numbers are mirroring the national averages. I wish they didn't, because that's a sad problem to have, but they are in line with a lot of what's going on nationally around the mental health of our students. We also know that particularly our gay, lesbian, and bisexual students are impacted. If we look at our students that are heterosexual that say they seriously considered attempting suicide in the last 12 months, that's 15%. But if you ask that same question, when we ask that same question to our gay, lesbian, and bisexual students, they're at 48%. Made a plan for suicide during the past 12 months, heterosexual students are at 12%, gay, lesbian, and bisexual students are at 36%. And then actually attempting suicide, this is one that's important to note, is that 6% of our heterosexual students said they actually attempted suicide, but 21% of our lesbian, gay, and bisexual students. So again, some real significant differences there, and that also helps us drive some of our programming to support these youth. I'll let Hanalea pick it back up here.
All right. Thanks so much, Ellen. So as y'all can see, we are seeing some very concerning trends. The pandemic has just really rapidly sped up the mental health crisis that we're seeing for our young people. And so the leadership of the Department of Health and Human Services realized that we needed to respond to this crisis. And where we are best positioned to respond to that crisis is in schools. I think many of you are in schools, so you know better than anyone that we can meet kids where they are by coming to schools. This is where young people spend the majority of their day. And what we know is that when we bring mental health resources into school, young people are more likely to actually receive those services, receive them quickly, receive them consistently, because it helps them and their families overcome major barriers. So transportation, stigma, the limited networks that are available in many of our counties around North Carolina. So we go into schools and we ensure that young people are more able to reach and access the care that they need. We are really seeking to optimize the behavioral health that we have in schools with a lens towards health equity. We know that by going into schools, we can overcome equity challenges because of those barriers that we talked about, and we can help build resilience. We're not just looking to bring resources for those young people who are in crisis, but also build resilience for all of the young people around the state, make sure that we're preventing them from ever getting to that point of crisis and really giving them the social emotional skills that they need to succeed. So in 2021, North Carolina was selected as one of 5 states that was selected to participate in the School Behavioral Health Learning Collaborative with ASTHO, which is the Association of State and Territorial Health Officials. So ASTHO was really a partner with us in this process of developing the Unified School Behavioral Health Action Plan, especially early on, as we figured out what was this going to look like, what was our response going to be. They provided us with technical assistance, and they facilitated site visits to really help us drive towards the vision of a plan. They also helped us to create this really, really essential cross-agency collaboration that we have with the Department of Public Instruction, that was so essential in making sure that this plan was not just reflective of the priorities of the Department of Health and Human Services, but also of the priorities of the Department of Public Instruction, as well as reflective of the expertise that they have about what it looks like on the ground in schools to be able to provide these services. So this is an overview of the process that we use to develop the plan. We started out with our core team of leadership, DHHS, Department of Public Instruction, external partners. Ellen will talk in a bit about some of those key partnerships that were so essential to developing this plan. And we started brainstorming what these strategies might be that we would put forth in the plan, and we put out a survey with all of our stakeholders to prioritize and finalize our strategy list and make sure that what ended up in the plan was what floated to the top for the vast majority of our stakeholders. We worked with additional stakeholders and work groups to refine our strategies, figure out what would be feasible to implement, figure out what it might cost to implement these. And now we are in this final step to realize the plan, which is that we are exploring funding options. The plan is in requested budgets from the governor's budget to the General Assembly. We are also working with private funders. We are really exploring all options to make sure that we do our best to bring these resources into schools. So as part of our early process and with key partnership with ASTHO, we conducted this gaps analysis to figure out, what was it that were the gaps that we really most needed to address with this action plan. And what we found was that there was really no centralized repository. People didn't really know what each other were doing in this space. There was a lot of question marks around, well, how many schools are doing this intervention? How many schools have a parallel intervention? What's out there? What are the funding resources? There really wasn't one central place to go. We also saw that there were overlapping policies addressing youth behavioral health, and in some cases, they may conflict with each other. We had obviously a major issue of a limited behavioral health workforce. That's true generally, and the support staff that we need in schools to make these resources a reality have been recognized as really, really limited and under-resourced. Obviously, we have funding challenges. These interventions cost money, and we had to figure out how we were going to get that money for these interventions. And we really wanted to, what we heard was that we needed flexible options, things that could address needs at the local level, things that could meet districts where they were, and recognize the differences between the different types of districts that we have across the state and their different student bodies, their different behavioral health resources, and the cultural settings in which they work. We also found out on the positive side that we're many phenomenal partners in the space. There were so many great things happening across the state, but they weren't necessarily speaking to each other. They didn't necessarily know what each other were doing and able to build on that knowledge and build on that experience from each other. So in this process, I also wanted to reflect the key voice that we heard from teachers and school staff. And I think that this quote from Lynn Gilliams, who is a teacher in Wake County schools, really sums up what we heard from a lot of the teachers and school staff that we spoke with on this issue. She said that the public believes that guidance counselors can meet the needs. My school has 1,400 students and 3 guidance counselors. They don't have time to do restorative circle groups or therapy, but the public has the perception that we have these kinds of services. The perception is that schools can handle this, but we can't. So, we were really hearing teachers and school staff are on board. They want these resources, they need this resources, and that this is really essential for them to be able to do their jobs, so that they can focus on the education of their students.
And Hanalei, if I can jump in right here on that just a little bit as I move, you can move on to the next stakeholders. I'll talk about that in a second. But it is really important to recognize that when we talk about those specialized instructional support personnel that do a lot of this work, they are social workers, counselors, nurses, and psychologists, and they all have very unique roles. So lumping them all together is not really accurate. They do different things, just like that counselor talked about providing group services. There's not enough of them to provide those kinds of services in the school setting. So a lot of times it's difficult because we really need to up those numbers so we have the kinds of supports and the teams of support that our students need. And that's something that became clear as we continue to do this work. We also, and when we began doing this work, decided we needed to talk about with different groups. I will say it was refreshing to me that a lot of folks talk about education, but don't include education in the conversation. And so it was so nice to be part of a conversation with so many of our partners. These are just a few of the stakeholders, but they were part of these conversations with ASTO. But we have done a lot of work to make sure we've continued these partnerships and relationships. And there was someone from each of these organizations sitting at the table as we began this work.
All right, so this brings us to what we're very excited to talk about, which is the actual Unified School Behavioral Health Action Plan that was released in March of this year and was the culmination of all of this work that we spoke about. This action plan really lays out a set of 6 key strategies that DHHS and DPI agree are key strategies that are needed to strengthen the behavioral health of our state. This is by no means a comprehensive list. It is not a strategic plan. I will emphasize that it is an action plan. This is us saying we are in a moment of crisis. We are in a moment where we need to act. However, this by no means is going to address every behavioral health need that our students have, every support need that our specialized instructional support personnel need, and it will certainly not meet all of the needs of our teachers. But what it will do is it will infuse support at a critical time and help us take key steps. The action plan acknowledges and is built upon the fact that we need additional resources for specialized instructional support personnel, that we are very under-resourced in that area, and that schools are critically understaffed. That is the foundation of these strategies, to say we are building upon that need for additional staff to support our teachers. However, we are adding in a set of strategies that are going to help us to build that resilience and build that response as we work towards fully staffing the personnel supports that are needed in our schools. So I'm going to go through each of these strategies and kind of talk through what they are. So the first strategy is our school electronic health record system. We currently in the state of North Carolina do not have one universal system that's available to all schools that allows them to document and share student health information across schools. Our schools are in vastly different places across the state with how they record student health information. Some of them use systems that are similar to the system we're proposing, but it doesn't communicate with the other systems that schools across the state are using. Some of them are still using paper or something like Excel, which really exposes our students to security concerns with their data. This is critical health data, and we want to make sure that it stays safe. What we know is that when students move across schools, that we know those schools need to quickly be able to learn what the last school knew about that student's health needs and what works for that student. And so by building an electronic health record system, we are going to be able to make sure that regardless of how many times a student moves in their educational journey, that information about the critical resources that they need and what works for them will follow with them. And I'm just going to send it over to Ellen to talk a little bit about how this pertains to student concerns of alcohol use.
Sure. I think what we're looking at when we think about a system like this is if we know that a student's had a challenge or a problem in one school district, for example, they had been um, received some type of what's the word I'm looking for? Some types of supports around alcohol use or other drug use in one district, but they move to another district. This would allow us to immediately get them in those supports in the new district. And what's been happening in the past is a student transfers and their record doesn't necessarily transfer with them. So we have to wait until the social worker or counselor or psychologist, depending on their need, or nurse talks to a parent and finds out what's happening. With the way we're looking at this system now is that we would directly know the minute a student walked in, did they have some kind of behavioral issue? Did they have supports in place already that we need to carry forward? All of those things would come with the student so that our specialized instructional support staff can support them better from the day they walk in the door.
So our next strategy is for school-based telehealth pilots for behavioral health. So what we know is that many of our students are in areas where behavioral health is very limited, or in some cases not available. And we are very interested in supporting those students who live in rural counties, other under-resourced counties, or whose families may have significant barriers to getting them to the care that is available. And so what we look at here with this strategy is bringing telehealth into schools specifically for the purpose of supporting student behavioral health. So we would, with this strategy, if it was fully implemented, we would be able to bring telebehavioral health to an additional 10,000 students who are currently in districts without these programs, and really focusing on those under-resourced districts, those rural districts. Because what we know is that about half of counties in North Carolina do not have access to a child and adolescent psychiatrist. That we see the same kind of shortages when it comes to other types of mental health providers. And what our data tells us from our North Carolina providers that we've worked with on the strategy is that when we have telebehavioral health in schools, students are more likely to get care after a referral, and that care is going to come faster for them because you just overcome those barriers. And so we know that these telebehavioral health services really work, but that very few schools currently have access to them. Only about 10% of schools in North Carolina, we estimate, will actually have telebehavioral health services in 2023. There are a number of other programs that focus on physical health, but the child psychiatry services and child therapy services are very limited in our schools. Our next strategy here is Project Aware, Project Activate. So Project Aware is a nationally funded grant from SAMHSA, And here locally in North Carolina, it's known as Project Activate. So we call it Project Aware, Project Activate to acknowledge both names. Project Aware is a grant that funds districts to basically create a comprehensive plan for behavioral health in this district. So, I talked early on about this plan is not that comprehensive plan for our entire state. It's an infusion, a set of strategies that we need in this moment. What Project Aware does is it for a single district, it allows them to create that comprehensive mental health plan. Everything from bringing those additional resources for resilience throughout the school to make sure that students' mental health is strong, that they have the social emotional skills that they need, to screening for behavioral health issues, to bringing care in when they need it. And currently in North Carolina, Project Aware has 6 districts that have been funded through federal grants to implement this Project Aware model. And 3 of our districts, their funding will end at the end of this fiscal year, at the end of it during the summer after this semester. And so we have seen such strong results for Project Aware Activate in the school districts that do have it. In particular, one thing that I will really call out is we've seen drops in school suspensions and expulsions as a result of this model. And so this is really important for keeping kids in school, keeping kids engaged with their learning experience, and making sure that we reduce those exclusionary practices that can really take a toll on a young person's education and their mental health. So we want to support Project Aware being something that stays in our state and that we are expanding upon. And to do that, we need an additional 2 years of funding for those first 3 districts so that they can really set up a sustainable model. What we're also doing here is we are looking at how do we take our best practices from the districts that do have this model and replicate them. What can be shared across the state so that not just these 6 districts, but districts across the state are benefiting from the lessons learned from Project Aware. So we also have a strategy here that builds upon some of the work that we've done over the last couple of years with federal funding for COVID-19 response in schools. So we have this comprehensive set of offerings and supports that we've given to schools over the last couple of years to support them reopening and addressing the mental and behavioral health needs of students that have arisen during COVID. And so a number of the strategies in the plan do build upon that work that has been successful or work that is really promising and that we want to continue. And this strategy here, school linkages to community resource networks, is the first of those in the plan. So what we have done with our COVID-19 funding is to work with schools to provide them resource mapping, training, to teach them how to partner with resources in their community, behavioral health providers, other resources in their community that are already out there, that are doing important work, and to bring them into a partnership with the school so that they can respond to a student's behavioral health need and they can coordinate with the supports across the student's care so that anyone who's involved with that student and the family would be able to come to the table and help the school to plan out so that that student can be most successful. So we are currently implementing this with COVID-19 dollars, teaching these schools how to partner with these resource networks, who is in their area, who they can lean on when a student has a need. And what we want to do with the strategy is to continue on that work, to build upon those lessons learned, to be able to continue strengthening that bond between schools and their community resource networks so that everyone is working together to ensure that student success. Another strategy that we have here that builds upon our lessons learned and our successes from strategies we've done with the COVID-19 funding is to support our school health advisory councils. So every district in North Carolina, per the State Board of Education, should have a school health advisory council, which is um, a body, a volunteer-based body of parents, teachers, school staff, and community members that come together to address and inform the behavioral health needs of their students. They also address other health issues, but here we are really focusing on that behavioral health piece. So what we did during COVID-19 was we recognized that every district is different. Every district has different needs and different contexts. And the folks that are best positioned to really respond to those needs, to recognize those needs, and to implement responses are these local bodies of parents and teachers and community members who are coming together to support their students and their schools for a healthy school environment. And so what we were able to do with the COVID-19 funding was that we gave schools across the state, their districts, their school health advisory councils received $60,000 in order to implement these interventions. And we just saw amazing work being done. We heard so much positive work that this really energized these volunteer-based bodies to come back together after COVID, that they were able to do things maybe that they had been wanting to do but didn't have the funding to do. And some of them got really creative. I also wanted to call out some of the initiatives that particularly some of our shacks have done that have directly addressed or have been shown to affect substance abuse, or particularly alcohol use. So a number of our districts, I would say it's one of the most popular things that has been done with the SHAC funding, was to invest in a social emotional learning curriculum. I'm sure many of you are aware that there are a lot of curriculums out there, varying levels of evidence, varying results that have been studied. I wanted to call out Second Step in particular because we did have a number of districts invest in Second Step, and Second Step is one of those social emotional learning curriculums that actually has been evaluated and shown to reduce alcohol abuse and substance abuse generally. And so it really speaks to the power that these local coalitions can have when they really are concerned about substance abuse to be able to bring resources into their schools. Another evidence-based curriculum that was brought in was Capturing Kids' Hearts, which is a professional development program for school staff. This is really about strengthening that teachers' leadership skills, strengthening the school environment, and they also have some results that are connected to reductions in alcohol abuse. We also saw some districts getting creative, not necessarily using like a ready-made evidence-based curriculum, but telling us one of our goals here is to reduce substance abuse. And so I will call out one of our districts actually developed a health education curriculum partnering with local law enforcement, specifically with the goal of preventing substance abuse. So certainly not all of our districts directly addressed alcohol abuse or substance abuse in their what they use the funding for. But for those districts that are really concerned and are really focused, this flexible funding gives them that option and gives them that resource. So what we're doing here with this strategy is to say this worked. We had phenomenal results. Our districts were so creative, and we want to continue supporting and resourcing these volunteer-based organizations. And so that is what we are hoping to do with this strategy. Finally, I'll speak on our final strategy, which is actually fully funded at this point. So it is the one that is furthest towards implementation. We hope to start rolling out training this summer and certainly into the fall, which is to facilitate mental health first aid training and youth mental health first aid trainings for school staff and students across the state. So Youth Mental Health First Aid teaches adults how to help an adolescent who is experiencing a behavioral health challenges and crisis. It gives them the skills to know what it looks like when a behavioral health crisis is in front of them, and it knows how to make sure that that young person gets to someone who actually has the skills, the knowledge, and the expertise to support them in that crisis. Teen Mental Health First Aid teaches teens. It actually creates teens ambassadors who can, when a peer is exhibiting signs of a mental health need or a mental health crisis, they actually can recognize that and they can get that young person to a trusted adult. So this is really about equipping our schools and our school staff and our young people with those skills to create an environment that's more supportive of mental health in our schools. And I think that absolutely will have an impact. With alcohol abuse, obviously, mental health first aid is really about mental health, but also behavioral health, and recognizing when someone is in need, which is obviously the first step towards making sure that someone gets the help that they need, whether that need is a mental health need or a behavioral health need, such as substance abuse. So I think this is just a summary slide of the strategies that we put forth in the action plan, and the estimated funding needs that's associated with them. So as I've emphasized, this is not a done deal. This isn't something that you'll definitely be seeing, on the ground next year, but we are very hopeful. We can say that mental health first aid is currently being rolled out. We are hopeful that the state school electronic health record documentation system will come soon after, hopefully by the end of the first semester of next year. And then the rest of the strategies, are funding dependent, but we are very hopeful about our path towards getting these into schools. The full plan, I would encourage everyone to take a look at it. It's a short read. I think it really will give you a lot more information about what we're doing and the evidence behind it, in particular why we chose what we chose and the impact we think it can have. So the link is here, and I encourage everyone to go and read the plan and share it with your colleagues.
And Hanalei, if you'll go to that next slide. So also that, that one. Also wanted to just let everyone know that we do all of this work within the context of the whole school, whole community, whole child framework. And this is a framework where the CDC and ASCD, so the academic organization ASCD and the Centers for Disease Control came together and said, let's work together, health and education, to put that student in the center and to provide them the supports they need in all of these areas, and do that within the context of the community in which that student lives. And I think a big part of what this plan does is allow us to do that, and then take this plan to each of those communities and see how it works for them, knowing that sometimes some districts have more specialized instructional support in some areas than others, or they may have to contract with mental health providers, but all of that within that community in which they're working. So when we think about it, we know that once we get children healthy, they will learn better, and that's our goal.
All right, well, I think that is the end of our presentation. So not sure, I couldn't see the chat while I was sharing. I will stop my
There are a few questions, Hanalei, and then we can open it up for others. I did want to go back. Someone asked about transgender youth early in that slide where I showed the LGB youth. Transgender youth are at great risk. I will say the Youth Risk Behavior Survey at this point doesn't specifically ask students if they're transgender. That's another question. And we have not added that question yet, partially because our numbers will not give us numbers just about those youth. Because our overall numbers of transgender youth are low, and we can't then generalize across the board with the numbers because the percentages are too low. That's not a reason not to ask. It's not there yet. We are moving, would love to move in that direction to ask that. But we do know that if it's affecting the lesbian, gay, and bisexual population, it is definitely affecting our transgender youth as well, if not more so.
So I see a question. Can you send us the slides? And it looks like the video will be shared out. I'm also happy to send the slides to our organizers for y'all to make available to those who have attended. That's totally fine with us. I also wanted to call out. I saw a comment about the need for more licensed social workers in schools. So as I stated, but I think I just want to re-up it, which is that this is really built upon the ask that the Department of Public Instruction is making for more specialized school instructional support personnel, and school-based social workers are an essential part of that. And so while it's not one of the 6 strategies, it's really, the basis that this is built on. I believe the Department of Public Instruction has requested an additional $100 million for those support personnel. Is that right, Ellen?
Yes, that was the budget request to the General Assembly.
And so we have data in the plan about just exactly where. I know folks are speaking in the chat about where we sit with our personnel, we have some data in the plan exactly about how we compare to the recommended ratios of students to support personnel, and indeed we are behind that. That is accurate. I see one. Are the monetary amounts shown the actual amount estimated or the grants that we have? So again, I want to emphasize these are requested amounts. This is what we envision needing. These requests are, some of them are in the governor's budget, but for those who follow the process, the governor puts out a budget, and then the General Assembly puts out a budget. So this is in the works. This is not us saying this is what's happening, we're fully funded. We are working towards that vision of fully funding these strategies. As I mentioned, we do have funding for the mental health first aid strategy, and we do have partial funding for the electronic health record. The other strategies, this is like a wish list at the moment. We're really hopeful that we will get at least some of these funded, and we are looking towards other funding like grants and like private funders. But at the moment, these are not fully funded, and so these amounts are what we believe we need to implement these strategies over the next 2 years.
In response to funding social workers, I did say that a bill was filed today to pay social workers at the master's level for those who are master's trained. And we know that master's trained social workers have a different set of skills than bachelor's trained in terms of their ability to provide certain counseling services. So we certainly are supportive of trying to get that pay scale to support those individuals and that level of education.
Yeah, and I see some comments about specifically about second step. I just want to emphasize we are not here to put forth any specific social emotional curriculum. I pulled out that one in particular just because of the link to this group and alcohol use, and I was looking for some examples of what our shacks have done that directly connects to alcohol abuse. There is a large spectrum of social emotional curriculums that have been funded, and I think what's so great about that piece of the action plan and what we've been able to do with the COVID funding is that this allows schools and parents and their partners to select the curriculum or even some other strategy that's going to work best for them. So we're not saying you have to use this curriculum or you even have to do this type of intervention. Some of our districts created quiet spaces for students or created a meditation garden, some focused on nutrition, so that there really was a lot of creativity to respond to whatever they felt was most in need in the districts. There's a question about our SROs involved in the action plan. I don't believe there's anything in the action plan that specifically addresses SROs, although I am not an expert in AWARE. I know that AWARE really, really focuses on reductions in that suspension, out of school suspension and expulsion. So I would imagine that SROs are a piece of that puzzle. Ellen, do you know any more about how AWARE is involving SROs?
I'm pretty sure they do, but I will also say that the Center for Safer Schools at the Department of Public Instruction has been funded quite well to help support the mental training for mental health for SROs. In addition to training on how to support students and keep buildings safe, but also about their emotional health needs. So there's quite a bit of training. They also do a lot of youth mental health first aid training on their own. So there's a lot of funding that goes to the Center for Safer Schools directly for SROs.
And the other thing I will say is I do know a number of our shacks, what they did with their funding was to invest in this training called Reconnect for Resilience, which is really focused on responding to trauma in others, but also reducing your own trauma response. And I do know that there is some work piloting that program with SROs. So I don't know specifically if any of the shacks that were using that curriculum were using it with SROs, but I know that there is some work in that area being done, and they certainly had the ability to select that as something that they wanted to focus on.
The bill that was filed was House Bill 762, school social work master's pay. And its companion bill is Senate Bill 524.
All right. I think we have answered any of the questions. If you have a lingering question in the chat and we missed it, maybe just put it back down in the bottom so that we can make sure we didn't miss it. But otherwise, but Ellen, would you mind adding the bills numbers in the chat? No worries. I know it's a lot to write down. Yeah, I don't think we have a bill number yet for the $1 billion roadmap, which will be, I think, school behavioral health, and this package will be incorporated into that. That is what we're hoping. So keep an eye out for that being filed, hopefully this week. That's going to be a larger piece looking at the dollars that we're going to be getting with our Medicaid expansion sign-on bonus, and how we can use them to strengthen behavioral health, really relying on the $1 billion roadmap that was published by the governor, and that the school behavioral health action plan is like a little slice of that huge comprehensive plan for strengthening behavioral health in our state, but it is a key piece of what we're hoping will be in that bill that is based on that $1 billion roadmap. And for those who haven't read it, I would definitely encourage you to take a look at that. That's really the bigger vision for strengthening behavioral health, and particularly child behavioral health. The link is not working. Let me try the link again. Maybe I had a typo in it.
And while she's checking, the link that I just put in the chat is for the Youth Risk Behavior Survey, or for all of our data. So if you'd like to know more of the data, that I only presented a small amount of the mental health data. So you're welcome to go to the Youth Risk Behavior Survey data for North Carolina and look at any of that. Feel free.
All right. I just put the link in the chat to the plan, so please someone let me know if it's not working. I'm also going to put a link in the chat to the $1 billion roadmap for those who haven't seen that. Like I said, that's the larger vision that this kind of wrapped around.
We so appreciate all of you being here today. Thank you for your interest, and we're happy to help any way we can.
Great. I'm glad it looks like the links were working, and I just put the roadmap link in as well. All right. I'm glad folks were feeling it was informative. We were happy to be asked to be here. And please reach out if you have any additional questions or anything else, and I will send that presentation so that the organizers can share it with you. Thanks so much, everybody. Have a great rest of your day.
Appreciate it.